today we're going to be exploring a very pertinent topic, one that's always high on the agenda, and we're going to be looking at OD red cells. We're going to be looking at why they're in such demand, why it's so important to us, what influences their use, and look at the ways that we can be smarter in how we manage this such a finite resource. Today we're joined by Jill Caulfield, who recently spoke about this very topic actually at the IBMS Congress. Jill is a very experienced BMS in blood transfusions. She's worked as a transfusion laboratory manager, and these days she's employed at NHS Blood and Transplant as the lead specialist in the bloodstocks management scheme. She's also the chief examiner for Transfusion Science at the IBMS, so very knowledgeable and very experienced on this topic. So we're going to get started with Jill. So I'm going to invite Jill to come on and take control. Just be aware that towards the end of the presentation, we will post an evaluation link. At that point, if you could just please complete that form, and that's how you will also receive your certificate of attendance. So without further ado, I'm going to hand over now to my colleague Jill, who will take over from now. Thank you, Jill.
Thanks, Danny. Okay, so as Danny said, we're going to look at how to manage your O-negative red cells in hospital transfusion laboratories. And we're going to look at why O-negative is so popular. We're going to have a look at how to manage your stocks, the appropriate use of O-negative, facts and figures, some take-home messages, and then we've got some question and answers at the end there. So why is O-negative so popular? Well, it's in such demand for many different reasons, and if we think about who's eligible to receive O-negative products, there are many things to consider. So firstly, our O-negative patients, particularly, can everybody hear me okay? Yeah. Particularly our O-negative patients, especially those patients who've got anti-D. We also use O-negative in trauma situations where the patient's blood group hasn't been confirmed. We use it in pre-hospital care initiatives such as the Helicopter Emergency Medical Service and Blood on Board. Pathology Modernization brought about the introduction of the hub and spoke models, where many hospital laboratories' stockholding practices changed. The BSH guidance brought the two-sample rule into hospital practice, and this has also had an impact on the O-negative stocks. O-neg is often substituted for referral laboratories to issue, particularly for complex patients with mixed reactions or to substitute the RO phenotype. And O-negative can be used for bone marrow transplant support prior to the patient seroconverting, as well as our neonatal patients who rely heavily upon O-negative before and after birth, perhaps for exchange transfusions or postnatal anemias. And we'll look at each one in a little bit more detail. So O-negative patients, so about roughly 7 to 8% of the UK population is grouped as O-negative. However, the demand made by hospitals upon this blood group is around 13%. We need this for our transfusion-dependent O-negative adults who should receive our O-negative red cells, and those with the clinically significant antibodies, particularly anti-D. And all females of childbearing potential less than 50-year-old and adult males less than 18-year-old, so not classed as adult males yet, they should receive O-negative red cells if they group and they are a true O-negative patient. So if we look at trauma, we use O-negative and it was standardised in major hemorrhage packs following examples from the military, where they used O-negative red cells for such events. Our major hemorrhage protocols have come a long way since then, and we recognise the need to have O-neg red cells ready, and there's a standard 4-pack normally ready in your pack 1 there, which perhaps replaced the old 2 flying squad that you would have to have in your blood banks. And O-neg is obviously, we all know it's considered the universal blood group in this instance, and not all hospitals have adopted the use of O-positive red cells to males and females over 50 in emergency situations. The air ambulance and response vehicles, they use O-negative for on-site emergencies, and this is where major hemorrhage is evident, the patient is classed as hypertensive, and the majority that are involved, are road traffic collisions. And we know that massive infusions of crystalloids into bleeding hypertensive patients can worsen a patient's outcome. The red cells are usually given alongside lyophilized plasma in a 1-to-1, and that's just freeze-dried plasma used from a single donation, or FFP is also carried on board now. And patients who are surviving these life-threatening injuries who might have died without this treatment, they are obviously, we're seeing the benefits of this. Now, the London Air Ambulance, they first carried blood in 2012, but how many carry it now? Well, this slide shows 17 of the 20 helicopter bases to demonstrate where they are geographically, and all except the Children's Air Ambulance carry red cells and plasma, and most carry O negative. However, some are beginning to carry O positive now, and we'll revisit this later on. Pathology Modernization, described within the Carter report, this brought about the introduction of managed pathology networks, where laboratories were encouraged to amalgamate their services and move hot and cold work to appropriate sites in order to improve turnaround times and ultimately to save the NHS some money. And many hub and spoke models were established and services were merged. And this led to a change in activity at many hospital sites, which was reflected in the laboratory stockholding practices. So some laboratories were transformed into a remote issue site. Perhaps they were staffed with non-qualified laboratory assistants where only Group O and usually O negative would be held and issued, and this had an impact upon our stocks. The 2-sample rule was introduced as a recommendation from the British Standards for Haematology, the 2012 Compatibility Guidelines, and it was recommended that all patients should have 2 blood group samples tested to confirm the patient's blood group before any red cells would be issued or transfused. And the samples were to be taken some time apart or perhaps by 2 different individuals to ensure that positive patient identification had taken place. And if only 1 sample had been taken, then Group O should be issued until that second sample had been received and confirmed. And this initiative was designed to tackle the wrong blood and tube errors, which was highlighted in short, where the blood's been issued to a patient with only 1 blood group result, however the sample was taken from the incorrect patient. And in some cases this had led to fatalities. So this led to an increase as well of Group O negative being issued. And although this is a new process and it's now this new process was now recognised, it actually is an ongoing requirement. There are some situations where O negative is used until a true blood group can be established, and there is national guidance for some of these situations. So the BSH states that where a sample label does not meet the sample acceptance policy, Group O should be issued until an acceptable sample has been tested. We also have patients with multiple or complex antibodies with perhaps limited availability, and Group O is normally issued in this instance, and it's one less complication for compatibility. We have multi-transfused patients, patients with rare blood groups or subgroups where a blood group cannot be determined by conventional lab methods, and it's safer to provide Group O. We also have interferences, so for example the monoclonal therapies, autoantibodies, or where a patient's being transfused ABO compatible but not ABO identical blood, and it's caused a mixed field or a dual population in your grouping card there. And again, a compromised blood group determination there, it's safer to give Group O. So some patients also have specifications that limit their ability to receive ABO identical red cells, and in such cases O negative red cells can be used as a substitute. And we tend to see this a lot in the RO subtype, which is little c, big D, little e. And the RO phenotype is very rare among our donor population and therefore difficult to supply. However, many of our sickle cell disease patients have this phenotype. And you can see that the phenotype of the patient is D positive, but little c and little e negative, and only 2% of our regular donors have this RO phenotype currently. As many sickle cell patients become transfusion dependent, it's important to try and provide phenotype matched red cells where possible. And this is to avoid the production of clinically significant antibodies, which would then lead to compatibility issues. And therefore the substitute for RO is normally with O negative, which is the little c, little d, little e, so little r red cells, as they are the closest match. And in the last year alone, we've seen a 13% rise in the demand for RO red cells. Group O negative red cells are usually used as well to support bone marrow transplants until the patient has seroconverted. So for non-ABO matched stem cell transplantations or solid organ transplants, where the donor or the recipient is Group O negative is usually selected to give there. And O negative blood's normally given temporarily in the event of severe hemolysis due to passenger lymphocyte syndrome. And you can see from the table there, from the recommended components in the early post-transplant period, it's mainly Group O that is transfused. So we supply O negative for our fetuses and neonates, and often with extra specifications. For example, red cells we supply for IUT, exchange transfusions. They differ more than the red cells that we would give for a fetal anemia or a top-up. And the objective of a red cell IUT is to prevent or treat life-threatening fetal anemia or hydrops fetalis, and allow the pregnancy to continue to a stage where a viable baby can be delivered. So ideally, at least getting that baby to 36 weeks gestation. And we would order in O negative red cells in CPD, which is citrate phosphate dextrose. We're looking at big C neg, big D neg, big E neg, and K neg, and obviously antigen matched for any maternal alloantibodies. We want them irradiated, and this is to prevent transfusion-associated graft versus host disease, CMV negative, less than 5 days old. As we know, red cells leak potassium the older they get, and this is to avoid hyperkalemia if the fresher that they are, and sickle screen neg as well. The red cells should have the patient should have a hematocrit of 0.25 between 18 and 26 weeks gestation, and 0.3 after 26. The components warm at 37 degrees immediately before transfusion, and that's an IAT cross-match. It's carried out with a mum sample. Exchange transfusion, this is to treat severe hyperbilirubinemia or anemia in babies with HDFN, and we have similar specifications to IUT, and it would be irradiated if an IUT had taken place. We could also use O negative for neonatal top-up transfusions and in major hemorrhage, which are quite rare, the major hemorrhage ones, but we do hold a stock, and those units would be in SAGM. So we have a little look at managing our hospital blood stocks, and this can have a huge influence on our stocks, so the usage and wastage of all the blood groups, but particularly O negative. And the blood supply in general has many challenges, so we'll have a look at those and consider what we can do to maximise usage and minimise wastage. So these are the thoughts that you'll have when you decide your stock levels. So how do you decide how much O neg to stock? What should be the maximum and minimal stock levels? What specifications should you hold? What if you run out? And what if you waste lots of O negative? What if you're stocking too much? So we should consider before deciding on a stock level, or either in a new or a review, all of these considerations. So what type of hospital do I work in? Do I work in a large hospital or a small district general? Am I a major trauma centre, as you'll carry more on O negative? Do we have a higher number of beds? If you've got a high number of beds, you've got a higher stock turnover. Are you a small site, perhaps, who holds very little stock or only O negative? What clinical specialties do you have? So do you have ECMO, cardiology, transplantation, haematology patients, chemotherapies, hemoglobinopathies? All of this will influence your decision. And do you provide support for pre-hospital care, so the air ambulance or blood on board? Other things to consider include how far away you are from your stock holding unit. So can you restock quickly if you need to? How many deliveries do you receive each day, and do you receive them at the weekend? And you shouldn't need to fall back on Group O. You should stock plenty of your other ABO groups. And stock only needs to last until the next delivery. So can you share stock with a partner site? You could rotate short expiry stock into a busier site or swap them out. And you can locate units quickly for other reasons, so for antigen negative or irradiated and other specifications. But are you close enough to that site to do that? Do we communicate effectively as well? So do we have good handover practices for close to expiring stock? Do we have an agreed time limit to categorise what short expiry is? So do we class short expiry as 1 day, 2 days, 5 days? And do we have visual and written methods for this information? Do we have electronic issue? So not every hospital does. So if you have electronic issue, you have less blood sitting in the issue fridge. And once it's reserved for that patient, it's unavailable to other patients, and you're more likely then to restock. If you already have 2 blood groups confirmed for the patient for electronic issue as well, so you're less likely to have to fall back to group O. And then how long do you leave those red cells reserved for? Is it 12 hours, 24, 48? If you go over 24 hours and you're holding stock for over 48 hours, those red cells are sitting there getting older each time, each day, and they're not available for any other patients. So where else do we stock our own egg red cells? How many satellite fridges do we have? Do we support remote issue? And how often do we rotate our emergency O units, and is it built into our processes? If we have a satellite fridge, is it full remote issue? Do we have the ability to restock out of hours? Are the staff who use it confident with selection, or do you need tight control? And could you stock other blood groups? Do you have full visibility of that stock 24/7? And what specifications do you need to stock? So are we thinking about stocking for males, females, paediatric patients? Does the laboratory control the issue? What do the guidelines say? And why have I asked for those specifications? There's a lot of variation in practice in laboratories when it comes to the specification of our own eggs, and we need to look at the guidance for our answers. So the BSH guidance states that females of childbearing potential should receive K-negative red cells unless they are unavailable in an emergency, and that patients with anti-D who are little r should receive little r K-negative blood. But do we know the phenotype of our emergency patients? Why are we ordering big C, big E negative units for our emergency units? And why are we exposing females to that little C antigen? There's also guidance regarding the use of O positive as an alternative to O negative. So group O red cells should be used in emergency situations where the ABO group has not yet been established. And if group O red cells have been given initially, it's recommended to switch to the patient's own ABO group as soon as it's determined. So for large volume blood replacement, which is classed normally as more than 8 units, D positive red cells should be issued to females over 50 and adult males, preserving stocks of O negative red cells for women of childbearing potential. Basically, you'd never know what emergency is going to come through the door next, and you don't want to use all of your O negative on a female over 50 or an adult male if your next person that comes in is a female less than 50. So moving on from that, let's have a little look at appropriate use. So a national comparative audit was carried out in 2018 and it was aimed to show where O negative red cells were going. And the categories included O negative patients, use for trauma, bone marrow transplant support, transfusion to other groups to avoid time expiry, and substitutions for specialised components where ABO identical units were not available. So if you just have a little think there about what sort of percentage you would think would be going to these patients. So which option out of these do you think is most likely to be true? So if anybody wanted to have a go at saying what they thought would be right, or perhaps pop it in the chat, I'll just give you a few seconds there to have a look at those to see where you think most of that O negative went.
Can you see the tool?
I can, yeah.
Great.
So a lot of people are going for option B. was actually option C. So everybody was a bit pessimistic there, but it was option C. So surprisingly, or not surprisingly, because everybody thought it was all 48%, only 59% of O negative red cells were actually transfused to O negative patients, and 12.6% was given to ABO compatible patients to avoid wastage, and 16% there was transfused to trauma patients. But is this our only option? Well, there's been an increase in literature supporting the use of OD positive red cells in major hemorrhage and trauma settings. And what we know is that D positive red cells can be issued to females over 50 and adult males. But does every hospital have this policy? How safe is it? And what does the literature say? So this literature has looked at the risks associated with alloimmunization and compared it to the benefits of getting blood into the patient as quickly as possible. And the outcomes show that there's very small chance of immunisation. So therefore, does the risk outweigh the benefit? Here are some of the quotes from the papers that we used. They used O positive, and they've explored the use of this in their trauma settings, and it was all positive. Excuse the pun. So what about in a pre-hospital setting? Well, we know that traumatic hemorrhage is the leading cause of death and disability in younger adults. More than half of potentially preventable civilian pre-hospital deaths are due to hemorrhage. Traumatic hemorrhagic shock in adults has a mortality approaching about 20% at 24 hours post-injury. And massively bleeding patients should be resuscitated with fluids that closely resemble what they are bleeding out in order to maintain tissue oxygenation and promote hemostasis. So do we take the risk for the reward? And again, there is supporting literature out there for the use of O positive red cells at the primary site, and this is ongoing. So what are our main concerns? Well, the main concern is the potential for a female to produce immune anti-D, increasing their chance of HDFN for future pregnancies. However, the decision to transfuse blood at the site of the incident is not taken lightly. It's only given to major hemorrhage patients where the situation is deemed life-threatening, and to those patients who are likely to need further ongoing transfusion support once they reach a hospital. We also know that we don't know what anybody's D type is at this point, but the risk of dying at this point is greater if they're not treated with these components early on. So is there any evidence to support the use of OPOS in this instance? Well, there are a number of studies and journals out there asking this very question. And Mark Yeaser from the US produced a paper in 2019 stating it is time to reconsider the risks of transfusing RHD negative females of childbearing potential with RHD positive red blood cells in bleeding emergencies. And he stated that if faced with the prospect of death from massive bleeding or the manageable risks of alloimmunization in the future, it is time to reconsider the risk of transfusing D negative females with D positive red cells in trauma and massive transfusion settings, and that the modern day probability of a D negative female exposed to D positive products becoming alloimmunized to the D antigen and then experiencing either fetal death or neurological morbidity in the child because of the anti-D they've produced is calculated to be approximately 0.3%. So in conclusion to this, early intervention with blood products has a positive impact on survival in massively bleeding patients. HDFN is now almost completely treatable disease with access to modern obstetric services. A woman cannot have a pregnancy affected by HDFN tomorrow if she dies from bleeding today. We need to preserve our O negative stocks for appropriate patients. They are a threatened resource. And with an immunisation risk of only 0.3%, surely the benefit of early OD positive intervention outweighs the risks. So let's have a look at some facts and figures. So nationally, are we holding too much O negative? So let's have a look at the data. We can see the total amount of red cells that are issued has fallen year on year, and you can see that in the red blocks there. And with 2020, you can see 2020 had the biggest decrease there due to the impact of COVID-19, and that was due to decreased activity within the hospitals. But let's take a closer look at the O negative issues in the blue bars there. So there is evidence of fluctuation in O negative issues over time, and the fall in issues from 2016 to 17 could be attributed to patient blood management initiatives, such as the use of alternatives, appropriate requests, single unit transfusions, etc. But however, the rise from 2018 to 19 could also be due to pathology modernisation, introduction of satellite fridges, pre-hospital care initiatives, and major hemorrhage standardisations. In 2020 there, it demonstrates the impact of COVID-19 on the issues there as activity had dropped. So unfortunately, with higher red cell issues comes increased wastage. And this chart shows the total O negative red cell wastage from 2012 to 2021. And you can see that it rose from 7,500 to over 10,000 units. And you can see 2020 is the highest number there at over 11,000 red cells. And this was due to the pandemic and subsequent inactivity. I can answer that one at the end, the little question that popped up. O negative accounts for about a third of total red cell wastage. So we've got the red cell wastage figures for 2019 here, before it all went haywire in 2020. And if we look at the total wastage for O negative red cells, how much do you think UK hospitals wasted in 2019 there? And we've got 4 options to choose from. So do we think that we wasted between 50 and 100,000, 150 to 300,000, 500,000 to £1 million, or between £1 and £2 million worth of O negative? Few people saying B, C. Got a little mix there going on, but most people are seem to be saying C. It was actually D. So the answer was D there. So the cost of O negative wastage in 2019 was £1,398,628. But most importantly, the donors have given up their time to go and donate, and this also has removed that unit from being of any clinical benefit to a patient. The total was actually over 4.4 million for total red cell wastage in 2019. And these figures are taken from Vanessa, and therefore they only include the data from the hospitals who participate. So we have got some high user hospitals who don't actually enter their wastage data. So this figure in reality would be much higher.
Volume? Yeah. Is it not there?
There are 4 main categories of red cell wastage data that we capture. So the first one is Timex, and these are units that have exceeded their expiry date. Odd-call, which is your out of temperature control units. Fridge failures, this is where the cold chain's been compromised. Or miscellaneous, and this could be for reasons such as a faulty bag or a DAP positive unit, for instance. So if we look at these figures from 2017 to 2021 there, you can pretty much see that Timex, which is the blue category there, is responsible for the wastage most over 60% of the time. So I was just wondering whether anybody wanted to have a chat about what you think might cause Timex wastage, or perhaps want to write it in the chat, that's fine as well. Overstocking. Keeping units on the ward, overstocking, poor stock rotation. Limiting use. Not placing the blood and expiry date in the fridge yet. Too long a reservation time. Yeah. So these are, you were absolutely right. Yeah. Yeah, we've got some more coming through there. That's great. Yeah, so holding too much stock, a lot of people mentioned this. So we should be reviewing our levels annually at least, or if anything's happened where we've had to, a situation has changed and we need to review our stocks. If you have too many unreserved red cells sitting in blood bank fridges as well, or insufficient activity, the units are getting older each day. And as I mentioned there, do you have electronic issue? There's no need to have any patients who are eligible for electronic issue. There's no need to have them red cells sitting in that fridge. Longer dereservation periods. So if it's over 24 hours, it means that those units are unavailable for other patients. Poor stock rotation. So yeah, it could lead to close to expiring units going unnoticed. Are we rotating stocks in our satellite fridges often enough? And ensuring that we leave sufficient expiry on those units to circulate them back into stock. Can we share our stock with a partner site, and are we giving them enough notice to try and get these units used? Poor red cell stock selection, could lead to short expiry units being issued to a patient who is less likely to use it, instead of issuing longer expiry dates to patients as a standby, for instance, where they're less likely to use it, and that to be returned to stock with plenty of time left on it. And there would be increased pressure as well to use returned and rotated stock from satellite fridges. Hub and spoke models, the hub receives all close to expiring units, so should we swap them out sooner? If you're a small hospital as well with low activity, but you need a stock there for those patients, and ultimately that's what we're here for. Or if you have multiple services, so the pre-hospital initiatives or major trauma centres, they'll always need higher amount of O-negative red cells, and ultimately patient care is our #1 priority. Therefore, it's always important to add that these are, not the only reasons, and the true nature of a blood transfusion service can be really unpredictable. So the next highest reason that we have for wastage is OTCOL, which is out of temperature control. So can you think of anything that might contribute to out of temperature control wastage? And again, I'll let you pop that in the chat or speak up if anybody wants to. Blood on the ward for too long, yeah. Major hemorrhage. Left on clinical areas, yeah. Porter issues, oh, don't blame the porters. Yeah, returned after a long period in the ward. So you can see that these, this tends to happen when the blood's actually left the laboratory. Clinical areas taken more than 1 unit at a time. Yeah, that has to be policed quite a bit, because I think they'd quite happily take a few units off to the ward and forget about them. So here we've got some of the reasons. So poor cold chain compliance after the blood's been collected there. So are your transit boxes fit for purpose, and do they provide the user with sufficient time? Collection of units when the patient perhaps isn't ready or they've spiked a temperature, and then you try and return the blood and it's exceeded your 30 or 60-minute rule, whichever one you have in place, and you may need to waste that unit once it's returned. The major hemorrhage packs, so the units have been requested for emergency situation, hasn't been used, but it hasn't been returned. And this can affect both O-neg and O-pos. And of course, our HEMS and BOB initiatives, the helicopter and blood on board there, with a constant O-negative red cell turnover. So some take-home messages. So for O-neg conservation, what can we do? Well, education and communication is vital, and hospitals should be aware of their O negative usage and wastage. They should monitor their performance and identify any issues that could threaten the O neg supply. We should understand the message from patient blood management strategies and encourage the appropriate use of O negative red cells. And it's up to blood services to recruit more donors, whether that's TV, radio, social media, etc. In terms of pathology modernisation, did hospitals reduce their laboratory stock holding of O negative when they installed and stocked new satellite fridges? This could potentially save some O negative units. There also needs to be regular recruitment drives for donors, particularly with the RO phenotype. Have all hospitals with major hemorrhage protocols considered the use of O positive as their emergency blood for all males over 18 and females over 50? And is this being rolled out for pre-hospital care? The 2 sample rule should be embedded and in practice now, easing up of our O negative stocks. But unfortunately, there is no second choice for our neonates or bone marrow transplant patients, so it's vital that we have O negative units available for these patients. So what can we do from a laboratory perspective? Well, we could only order what's needed until the next delivery. We don't overorder unless clinically required. We can share stock where possible and perhaps rotate the stock regularly or swap out units that are older with busier sites for some newer stock. We can regularly review our stock levels, perhaps annually if you haven't done it already. And after a significant change, so for example, if you bring in a new satellite fridge, have you reduced your stock holding because you have moved some blood into a different fridge? Have you had an amalgamation of services there where perhaps you can start to rotate stock? Or have you got a new service on board, so a new haematology unit where you perhaps need to hold more stock? We should perform audits and target areas of inappropriate use and wastage. We should look to only order O negative, K negative. There is no requirement for big C and big E negative units for emergency purposes. We should always consider the use of O positive for females over 50 and adult males where there's no anti-D for emergency issue and to support pre-hospital care. We should check all issued stocks, satellite fridges and other sites before ordering new stocks. And have good communication, so highlighting close to expiring stock, and this is at shift handovers or to partner sites. So in conclusion, who should receive our precious O negative red cells? Is it our patients with anti-D? Is it patients with massive hemorrhage? Is it our multi-transfused and complex patients? Is it our neonates or our transplantation patients? Well, everybody counts, and it is our responsibility to monitor our stocks, use them appropriately and minimise wastage wherever we can. So thank you, and I've got a few questions here for some discussion. So should a small independent hospital only stock O negative, and what are the pros and cons? Should we provide only O positive red cells for pre-hospital initiatives, and how can we tackle our Timex problem? Well, if you look at the first question, so should a small independent hospital stock O neg? Can we think of any pros and cons? So if anybody wants to have a chat, that's great. If not, if you put something in the group chat, if you put whether it's a pro or a con. Anybody? So if you're a small independent hospital, should you only be stocking O negative? What if we take the pros first? What if we think of the reasons why it would be good to only stock O negative for those small hospitals? Yeah, so pro, you don't need to stock alternatives. Reduce wastage of less common groups. Yeah. Can give it to anybody who comes through the door. Rarely use blood, but still need urgent blood. Yeah. What about the cons? Mixed field reactions in ABO. Yep. Takes non-group O patients off AI. You need to cross-match. Yep, lots of manual cross-matches. Yeah, because perhaps those patients might be transferred on to a larger hospital, you never know, and they're going to have a mixed field reaction there if they need further transfusion support. Okay, well, we'll have a look at a few I jotted down. So the pros, so it's a small laboratory, you might only have small amount of space and a small fridge. Minor surgery, so they're less likely to use blood anyway. On a lot of these smaller sites, and the types of surgery where we're not expecting the patient to bleed. There might be a BMS only on site 9 till 5, so this O negative in the fridge could be a safety net. Put minimal training because it could be that the BMS who's actually at this site, because it's such a small site, their initial training might not have been in transfusion, it could have been in biochemistry. So multidisciplinary staff, yes. So it'd be easier just to issue something like the O negative or O positive, and people might feel more comfortable with that. But the cons to this are that the patient isn't receiving their own blood group, and that would lead to mixed field reactions. Perhaps it's inappropriate use of O neg. And what about our adult males and females over 50? Could they receive O pos? And what is the backup if the patient starts bleeding? It's a limited resource. And what happens during a shortage? What is the backup plan? So any other comments? Yeah, you're mixing the patient's RH, yeah. I don't know if I've covered everything that was in the group chat. I couldn't see all of them as they went past, but I think we've covered most of it. Yeah, usually not many bleeding patients or major hemorrhage scenarios in the small hospitals. We would hope so, yeah. So there are pros and cons to this as well, isn't there? It's not just clear cut. Okay. Patients that are not suitable. Yeah. So should we provide only O positive red cells for pre-hospital initiatives? So this is literally at the site of where the injury is, so at the roadside, etc. So this is your helicopters or blood on board. This is not when they've reached the hospital. This is literally what is carried on board. Yeah, you should, but need to be led by guidelines. Yep, but the guidelines do just state Group O. Okay. So I'll put yes, only because urgent care, the patient is hemorrhaging and red cells are the best replacement for volume at the time. It is mainly males that would affect. I'm just reading that, sorry. It is mainly males who are treated for major hemorrhage in these situations. Shouldn't assume gender if patient is non-responsive. Yep. So I'm just saying I'm just saying yes to use it for male or female or anybody at that point in time. So just carry O positive for anybody who would need it. There is a small chance of sensitization, and as we've mentioned before, it is manageable. And O neg conservation as well for patients who can only receive O negative. There are studies, more studies coming out about using O positive in these situations. I think the guidance will be looked at again. There are some helicopter emergency services in the UK who are now carrying O positive. I think everyone's too nervous to change to O pos. Yeah, if it was in the guidance, then I think people will feel happier about it. But it is coming. It is starting to be looked at. And like I say, we have got some helicopters up and down the country who are only carrying O positive as well. So that's an interesting point of view. And then how can we tackle our Timex problem? So if anyone's got any good ideas to share. Reduce female age to 45. Oh. Better IT system to manage stock. Update stock rotation. Yep, education for staff. Education is always key for things like this. Education for clinical staff. Well, that's fine, but it's not the clinical staff who select the blood from the fridge. So I think the Timex problem tends to be one of our issues rather than the hot call, which I would think would be best for outside of the laboratory. But certainly stock rotation. Reserve short dated blood for emergency. So I would imagine people who have their emergency stock sitting there pick the longest expiry on it so that you don't have to rotate it as often. But that should be kept an eye on, you know, especially in the satellite fridges as well. Better transport box management and training. Interesting. So I had just popped a few answers down there. So looking at our stock levels to start off with. In blood stocks, we can provide an ISI, which is your issuable stock index. And this is data for your hospital to see how many days of stock you're actually carrying for each group. Reviewing your stocks regularly or annually together with your wastage data, and reduce your stocks if your wastage is high or increased Timex. What was that coloured markers? I didn't quite see that one there. Organise me stock well, yes. So put on there clever stock rotation and selection. So if you've got patients who are there for a top-up, they're going to be seen to quickly, given a transfusion, and they're out that day, great, that you use your close to expiring stock. If you perhaps popping some stock out for somebody who's in theatre but they don't think they're going to use it, but they're not sure and it's just a standby, you pick stock with a longer expiry date on it. To share stock, so swapping out stock with busier sites and highlighting close to expiring stock. Just having a look down the chat here. A system used by blood component suppliers that allow for the acceptance of units that are unlikely to be used. I don't have a magic wand. That would be quite nice. I think you're very lucky if you've got a partner site who you can share and rotate stock with. And geographically, some places just don't have this. So we have to be smarter with our stock selection. and maybe hold less stock in the first place. So stock levels they dipped quite a bit in COVID. Everybody learned very quickly that they had to reduce their stocks, but stocks are creeping back up again. But we did manage with less. Don't know if there's any other comments. Hope that was useful. Better implementation of the maximum surgical blood order schedule. Yeah. I guess your MS BOSS now, it kind of exists for patients with antibodies, really, because most of your patients, or a great deal of your patients, will be electronic issue anyway, and hopefully you won't be putting blood out for those for too long. And if you do, maybe you're just for 12-hour turnaround, so maybe shorten your dereservation time as well.
Yeah, thanks, Jill. That was really good. Thanks so much. I hope you guys found this really useful.
Someone's just put in there, do you know if APOS whole blood is to be considered? I'm not sure where the APOS bit comes from, but I would hope we wouldn't be giving APOS out to everybody. But whole blood is being looked at. It was a typo. Yeah, so whole blood is being considered and being looked at to bring back in the emergency setting, and I think it started off in the military. They've been looking into that as well. So I would think in the next few years that will be getting looked at, instead of bringing red cells and FFP separately on board for emergencies.
Okay, so just a thank you from me to everybody who attended, and a special thank you from the group to Jill for coming along today and giving a fantastic talk. As Selma said, do come along next month and join us again for the next session, and we'll see you then. Thank you very much.